عم بتشوفوا سكرين؟
ايوه واضحه.
ليك خالد على راس سكرين عم بيجيني ميوت ستارت فيديو بارتيسيبنتس chat new chair. هيدي كيف في شيلها؟ لان هيدي بتضايقني when I'm giving the talk.
يا صلاح بتسمع الدكتور جون ايش بيقول؟
ما بعرف ما
دكتور بسمع.
هيدا عم بتضايقني
كيف يشيلها؟ كيف يشيلها هذه؟
هو أنا على فكرة أنا مش عامل الدكتور هوست.
مش عامله؟
الدكتور مش هوست، الهوست أنا.
انا عارف مش الهوست، لكن في حاجه بتظهر عنده يعني كيف يشيلها؟
بتيجي لعندي كل حال انا مش مشكله رح بتصفي
ممكن نفعل
بتاخر شوي. If you can help me remove this I will appreciate it.
هو يا دكتور جون صلاح بيقول انه الان انت يعني ما بتجي لك ازعاجات لانه الهوست هو يعني من صنع الهوست، وبالتالي اي حاجه امسحها عادي خذ راحتك، يعني تطلع فوق وتمسحها ممكن.
عم جرب امسحها ما عم بتروح، يا بتطلع لفوق يا بتنزل لتحت. You are screen sharing stop share وفوق السوداء.
ايوه
هيدي ما بتروح ابدا.
كبر الشاشه ممكن لما تكبر.
ما الشاشه رح بكبرها ورح ببلش. يلا
بسم الله ان شاء الله.
Okay, is it clear now?
Clear.
Okay. The topic today is fracture repair and biomechanics. As you all know, the skeletal system, through coordinated biochemical and biomechanical processes, اثنين سوا, biochemical and biomechanical processes, is capable of restoring mechanical and biologic stability after injury. هيدي بتصير بالبone, and it is most common to occur in bone. Bone is the only tissue that can be repaired completely and then refunction according to the lines of stress. You have to know this. Compromise to the bone can be the result of direct injury, neoplasms, infectious conditions, and deprivation of essential nutrients when the blood supply is disrupted. انتوا بتعرفوا يا شباب لما بينكسر العظم, there is disruption of the blood supply. So you have loss of the nutrients. There are ways to recover it, and I would attempt to explain this to you in this lecture. Okay? Now, the interaction of progenitor cells, these are the basic cells, the cells that supply inflammatory cytokines, growth factors, host biology, and mechanical environment provides a setting which enables bone to heal in an organized and predictable manner. What I mean, you have endochondral bone formation and you have membranous bone formation, and you have mesenchymal cells. Mesenchymal cells are the cells out of which all other forms of cells can form, and they would do the function to repair the bone once there is an injury, a fracture, or whatever it may be. When bone incurs a traumatic injury, a biochemical response is initiated secondary to direct cell damage. This sequence has classically been broken up into 4 phases. هيدي بدكم تحفظوها. Inflammation, soft callus formation, hard callus formation, and remodeling. I repeat, inflammation is the first stage. soft callus formation, the second, hard callus formation, the third, and remodeling, according to the lines of stress, is the final stage. Injury occurs to the local bone and soft tissue. لما بينكسر الإجر، لما بيكون في كسر بالفيمر، مش بس بيكون في injury للبون، بيكون في injury للsoft tissue and the blood supply. So you have to think of this. What happens? You have a hematoma formation. This hematoma with a fracture is different than a simple hematoma of soft tissues. Why do I tell you this? You will come across this in my lecture. If you take the hematoma following a fracture and you translocate it to a different area, you'll see with time there will be new bone formation. So it is different in character than other hematomas. I repeat, hematoma occurring with a fracture. Inside the hematoma are numerous mesenchymal stem cells. To give it a short name, it's called the MSCs. I will continue either full name or not. This generates growth factors to aid in the differentiation of osteoprogenitor cells. شو بيعني osteoprogenitor cells? These are cells that are involved in bone formation following an injury, like an osteoblast, like osteoclast, like cartilage cells. All these are involved in the repair process, and they all originate from the mesenchymal stem cells. حطوها براسكم، حطوها براسكم، ما تنسوها هاي. In the absence of surgical intervention, these cells, over a period of days, begin to form soft callus. هيدي بتيجي من بعد الانفlammation. And this soft callus is composed mainly of cartilage, primarily of cartilage. Don't forget, you have the hematoma, you have the cartilage, which takes part in the formation of the soft callus. As this matrix becomes calcified, it becomes the hard callus. What happens with the hard callus? You have the function of osteoblasts and osteoclasts. One forms bone and the other destroys bone. One stimulates the other to create the passage for it to go in the tunnel and lay down bone. ما تنسوا، الأوستيوكلاست resorb bone. The osteoblasts stimulate the osteoclast to resorb bone through the production of rankle. Rankle acts on the osteoclast to erode bone through a tunnel which is started as Hoship's lacunae. So don't forget this. So in the hard callus, you begin to have the function of the actual cells that form bone. Now, in the hematoma, you have the inflammatory phase, you have the invasion of neutrophils, macrophages come in, etc. But in the hard callus, you begin to have cells that form and destroy bone. The final phase is called the remodeling phase, and this involves restoring the marrow cavity. Now, when I say it restores the marrow cavity, What do I mean by it? It restores the biomechanical function that should be present after this healing process occurs. إذا بتلاقوا إنه في stress on one area more than the other area, you'll find that there will be more resorption in the area which has no stress and bone formation in the area of stress. And this is what occurs with Wolff's law when we will talk about it in the future. The presence of appropriate nutrients and blood supply are basic requirements, and cells, including osteoblasts, osteoclasts, chondrocytes, and endothelial cells, must all be present. The extracellular matrix means the medium in which all these cells are present. This is produced by the cells recruited to the fracture site, and this must provide a setting that promotes each successive phase of healing. What about the cell responsible for fracture healing? Am I clear so far? Am I clear؟ عم تسمعوني يا شباب؟ خالد.
دكتور جون كل شيء واضح جدا. كل شيء واضح تمام.
Please, I want to repeat many times. I have to have this clear in everyone's mind.
Okay.
What about the mesenchymal cells? Certainly. Mesenchymal cells are stored in the bone marrow, in the adipose tissue, and synovial lining. One question I could ask: where is mesenchymal cells stored? Is it in the bone marrow? Is it in the synovial tissue or lining? Is it in the adipose tissue? Is it in all of the above? Is it in none of the above? The answer is all of the above. Don't forget these points. In the face of acute fracture, cytokines influence differentiation of mesenchymal cells to osteoprogenitor cells through interactions with specific cell surface antigens. Mechanical environments, as I've repeatedly say, also play a role in mesenchymal cell differentiation. يعني إذا بدنا نعمل عظم, it will change more to osteoblasts. إذا بدنا نعمل destruction or remove bone, it will have more osteoclasts with pseudopods acting on bone to resorb bone. So the mesenchymal stem cells are the source. Now, they also play a role in differentiation, favoring chondrocyte differentiation in mechanically less stable environments. Why? Because chondrocytes can bend. They are the primitive form of bone formation. They are not the stable form of bone formation. When we have bone formation, it is stable. When we have cartilage, it is not stable. It's still weak, the callus. What about the chondrocytes, the osteoblasts, and osteoclasts? Chondrocytes and osteoblasts are key players in the mechanism of fracture healing. هن الأصل الchondrocyte والosteoblast. When a bone is injured, these cells differentiate from mesenchymal cells, which are brought to the fracture through vasculature and inherently present in the periosteum and endosteal regions surrounding the bone. And this gives the name to periosteal bone formation and endosteal bone formation. Keep this in mind. Recent evidence suggests that the periosteum and tibble, periosteum, the covering of bone, the covering bone, where you have the osteoblast, you have the cambium layer. Cambium layer means immature osteoblast, which will change to osteoblast on demand. The periosteum as the main source of chondrocytes during the acute phase of fracture healing, while the periosteum and endosteum supply the osteoblast. So ما بدي اياكم تنسوا، قلت لكم اول شيء انه اهم شيء الكوندروسايتس والاوستيوبلاست. هلا بالكم شغله ثانيه، in the periosteal layer you have chondrocytes being formed. In the endosteal area, you have osteoblasts, osteoclasts. Now, depending on the signals, the information عم بيجي ليهم. The signals present in the extracellular matrix a pluripotential mesenchymal cell. This will differentiate in chondrocyte or osteoblast. برجع بعيد, the origin of all these cells are from the mesenchymal cells. They supply chondrocytes and osteoblasts. The periosteum supplies more chondrocytes. The osteoblasts are being supplied by the endosteal region. What I mean by endosteal region is within the medullary canal of the intact bone. The chondrocytes are the main producers of the extracellular matrix. They are in the background. They are within the extracellular matrix. And these chondrocytes, together with the proteoglycans and collagen, which is formed by the chondrocyte, fill in the extracellular matrix. These have a weak strain. They bend. They are not stable. So when the chondrocytes are formed together with the proteoglycans and collagen, this is a sort of a more elastic bone. When a fracture heals, the chondrocytes hypertrophy. كلكم تعرفوا. With maturity, the chondrocytes hypertrophy and they undergo apoptosis. What do we mean by apoptosis? They are destroyed. They are eaten up by bone. They are replaced by bone. This allows for vascular invagination, and the cartilaginous matrix is then ossified through deposition of calcium by the osteoblasts. أقطع enemy للcartilage هي الكالسيوم. When the osteoclasts, in the final stage, when the chondrocytes hypertrophy come, they deposit calcium on the dead chondrocytes and they begin to form bone. In other words, the chondrocytes create a scaffold. What I mean by scaffold, a route by which calcium is deposited on and osteoid tissue is formed. This is more solid, and this is the beginning of the formation of the hard callus. So the osteoblasts produce osteoid, which is the main component of bone made up of primarily type 1 collagen. A question that I love to ask. مين في شي سؤال؟ Osteoid consists of type 1 collagen. This is the major type of collagen present in bone. A question that I love to ask is, what is the most frequent type of collagen present in bone? They can be found on the surface of bone and are responsible for bone homeostasis by balancing bone formation with bone resorption done by the osteoclast. The osteoclast activity can be identified in vivo due to the presence of alkaline phosphatase, which is an enzyme that causes dephosphorylation. So, another question, how can we identify in vivo the presence of osteoclasts? Always associate alkaline phosphatase with osteoblasts. Please keep this in mind. Now, osteoblasts are derived from, I'm sorry, osteoclasts. I cannot see and head covering. Osteoclasts are derived from the macrophage monocyte cell line, which originate from pluripotential mesenchymal cells. إذا بتتذكروا قلنا لكم بالinflammatory phase following a fracture, we mentioned that you have a hematoma, and within this hematoma, the mesenchymal cells send macrophages and monocytes together with polymorphonuclear leukocytes to the area of the injury. Now, on the bone surfaces, these osteoclasts, as I mentioned before, reside on Hosch's lacunae. Please, in the exam, if I ask anyone, what is Hosch's lacunae? You have to know that it is the site of residence of osteoclasts, and if they have pseudopods and they are viable and they are not dead and they are eroding bone, it creates a cavity through which it erodes bone. What follows, the osteoclasts, they stimulate the osteoblasts, they stimulate the osteoclasts through rankle. The osteoclasts destroy the cartilage, destroy the soft callus, and they follow and lay down calcium, which is deposited on the cartilage. So never forget this. The osteoclasts lie within Hosch's lacunae on the surface of bone. Okay, their main function is to resorb bone in a remodeling process coordinated with osteoblasts. They resorb bone through a tartrate resistant acid phosphatase, which is regulated by a receptor activator of nuclear factor kappa beta ligand. We call it rankle. It's easy. It's easy for you and for me. And a calcitonin receptor. So I repeat, they resorb bone through a tartrate resistant acid phosphatase. Keep this in mind. This is regulated by two things, the rankle and the calcitonin receptor. Don't forget this. What are the types of bone healing? The type of healing that will occur depends on both the mechanical and the biological environment present. There are two types of bone healing, as I have repeatedly mentioned: endochondral bone formation and intramembranous bone formation. Let us give you an example. This is an anteroposterior radiograph of a long oblique midshaft humerus fracture in a 76-year-old female being treated non-operatively in a Sarmiento brace. What I mean by Sarmiento, it is by two splints applied on the fracture side. We usually apply it around 2 to 3 weeks after the fracture, and we wait for it to heal. This brace allows significant motion at the fracture site, and this favors endochondral ossification. We begin to see that there is more callus in endochondral bone formation. There is very minimal, if any, callus formed in membranous bone formation. Over here, this patient had a fractured radius. What was applied was a plate. And in the past, we used to apply compression. By applying compression, the fracture will be so damn stable that no bone is formed. And it allows absolute stability. And this heals without callus, with intramembranous ossification. So I want you to put in your head endochondral bone formation and intramembranous ossification. Endochondral means that there is motion. It's unstable. So you have callus. Membranous ossification, it's solid. It is stable. So there is primary bone formation. Never forget this. So endochondral ossification is the process whereby an existing cartilaginous matrix is replaced by the bone. Chondrocytes lay down mature cartilage and then slowly hypertrophy, and they age. What I mean by senesce, they age and they're destroyed. Vessels invade the cartilage, which allows osteoblasts يشرفوا مثل الخواجات and replace the chondrocytes in the scaffold مثل bridge. The bridge is the cartilage which is undergoing hypertrophy, and it is undergoing aging and being destroyed. The vessels come and destroy the cartilage, and they form, deposit calcium, and they begin to form osteoid bone, which is more stable than what it was. This process occurs both during normal human development and fracture healing. Historically, this type of bone healing was referred to as secondary bone healing. Involved 4 stages and usually meant there was motion at the fracture site. Yani inflammation, soft callus, hard callus, remodeling, all these tell you that these stages occur in secondary bone formation, and it tells you that there is motion at the fracture site. So, endochondral ossification, what I said, repetition. You have fracture hematoma, you have the inflammatory phase in the first 24 hours after injury. This is the result of local disruption of the vasculature, periosteum, cortical bone, and the surrounding muscle. Fracture hematoma, as I mentioned, and this I want you to keep in mind, is unlike hematoma or blood clot resulting from soft tissue injury alone. Please don't forget this. The hematoma from a fracture is different than a hematoma from a soft tissue injury. The hematoma from a fracture, if you deposit it elsewhere, it will form bone. The hematoma from a soft tissue will not. And this explains, خليني أفسركم إياها, in supracondylar fractures of the elbow in children, you see that there are some patients who develop a heterotopic bone formation. What happens? You have a fracture, you have a hematoma, and this is a fracture hematoma. It has the cells which form bone. The brachialis muscle is injured, so you have deposition of tissue that can form bone. And this is the explanation why you get heterotopic ossification in some fractures of the elbow. Mizuno et al. Transplanted 4-day-old fracture hematoma to remote locations in the rat model, and it resulted in ectopic bone and cartilage formation. Macrophage, platelet, and neutrophil arrival at the fracture site marked the beginning of the inflammatory phase of bone healing. These cells release inflammatory cytokines, which includes tumor necrosis factor alpha and beta, and interleukins of 1, 6, 10, and 12. These inflammatory molecules play an integral role in enhancing the inflammatory response to recruit multiple cells from the surrounding bone marrow and periosteum, leading to growth factor production. Don't forget about the fibroblast growth factor and the basic fibroblast growth factor. These are some of the earliest growth factors present at the fracture site in hematoma. So don't forget, these do occur. They help promote differentiation of mesenchymal cells to chondrocytes and osteoblasts during bone development and stimulate cartilage formation and increase the size of the fracture callus. In other of the growth factors detected early in inflammation phase of bone is the platelet-derived growth factor, PDGF. Nash et al. Demonstrated a stimulatory effect of fracture callus and early stability in rabbit model when treated with PDGF. This study also showed advanced microscopic differentiation of the rabbit tibia treated with PDGF over the control. What about bone morphogenetic problems? Bone. يا جماعة, the BMPs should be known to all orthopedists. The ones that we respect are the BMP2 and 7. These have been studied extensively, and their stimulatory effects on bone healing are well known. BMPs are capable of recruiting stem cells from distant sites, inducing osteoblast and chondrocyte differentiation, leading to ectopic bone formation. So don't forget this. Clinically, recombinant BMPs, especially BMP 2 and 7 have been used in non-union treatment and encouraging fusions. Level 1 evidence suggests that BMP2 improves the repair of open tibia fractures, while prospective case series have shown that BMP7 is also effective in treating tibial and femoral non-unions. We use this. We use it as orthopedic surgeons, but this is very expensive, but it helps in promoting union in conditions in which we have non-union of the tibia and femoral, and we use it on the posterior aspect of the spine during fusion. Remember, this superfamily transforming growth factor beta D, TGF beta, is present at the fracture site during the first few days of the inflammatory phase and has a minor effect on callus size and strength. So don't forget about the platelet growth factor. Don't forget about the BMPs. Don't forget about the transforming growth factor TGF beta. Don't forget about the fibroblast growth factors. All these are present early in the hematoma, and all these growth factors are involved in inviting mesenchymal cells to change into osteoblasts and chondrocytes during the process of callus formation. Soft callus phase, I will go through it very quickly. But you have to know this. I'm repeatedly saying it in different ways. The mesenchymal cells condensate around the fracture site, and as a response to growth factors and cytokines differentiate into chondrocytes and osteoblasts that I've repeatedly said. The stability of the fracture site determines the direction of differentiation. More instability at the fracture site lends to chondrocyte differentiation and endochondral ossification, while stability at the fracture site promotes osteoblast differentiation and intramembranous ossification and primary bone healing. Puzzle. Instability, cartilage. Stability, osteoblast, and primary bone formation. Never forget this. The production of cartilage stabilizes the fracture and forms the soft callus, for which this phase of bone healing is named. Both endochondral and intramembranous ossification occurs simultaneously during this phase, with the former being the primary mode. Yani, endochondral is much more common than membranous. Stability of the fracture site promotes intramembranous ossification. The hard callus and remodeling phases as the final stage, as the cartilaginous matrix is transformed through endochondral ossification, the soft callus becomes hard callus. The final stage of this process involves chondrocyte maturation. As I said, they hypertrophy and they are replaced by bone. The chondrocytes express collagen type 10 and begin to degrade the extracellular matrix. The cartilage becomes calcified and the chondrocytes undergo apoptosis through organized osteoclast and osteoblast activity. The newly formed bone remodels. Yeah, Shabab, yes, it did. I gave you bone healing now. Bone healing, you should never forget it. I've repeated so many important points. and I want you to memorize it. I want you to keep it within you. This is the basics of orthopedic surgery, the basics. And I'll tell you, in the board, many examiners are not well acquainted with it, but you should be acquainted with it. Yeah, Jamia, the junior staff on many occasions should teach the senior staff, because the senior staff go away from these learnings. We learn from you, your junior staff. Give us the pride of learning from you. A bit about intramembranous ossification. It is the process of direct bone formation without cartilage precursors. Direct deposition of bone through the cells of mesenchymal origin leads to new bone formation without the creation of callus. Again, this mode of bone formation occurs during skeletal development and during fracture repair, where there is rigid fixation. Never forget this. This has been historically referred to as primary bone healing. The AO people love it, and they speak about stability. But nowadays, the trend is more to create an elastic zone for better bone formation. This will be discussed later on. Okay, and the primary bone healing restores the lamellar architecture of bone in a fracture which is stably fixed, resulting in disappearance of the fracture lines on subsequent radiographs. And this is very true. If you have stability and you're promoting primary bone healing, you don't see callus. Os joints grow in and they replace the fracture site, and you don't see a sign of any fracture. Bones heal directly through osteoclast lead cutting cones, which cut a linear path across the fracture site, and osteoblasts lay down cortical bone. Now we come to the mechanical aspect of bone. It has long been understood that the mechanical environment surrounding a fracture influences healing. For centuries, fractures have been stabilized by external means in order to improve patient comfort and prevent displacement and encourage time to union. Over the past century, the understanding and techniques of surgical fracture stabilization have improved this process and affects micro and macro motion at the fracture site, and these are better appreciated. Mechanical stability favors primary bone healing through intramembranous ossification. The concept of absolute stability in fracture fixation, fixing the fracture fragments with rigid internal fixation to prevent micromotion at the fracture site, optimize the mechanical environment for direct bone healing, and as a result, we have cutting cones and no cartilage intermediate. Don't forget this. These are the stages of bone healing. I will not go through it, just for you during review to know that. So we mentioned that instability endochondral, and you have primary and secondary bone healing that I've spoken so much about. Now we come to the strain theory, a principle first described by Perrin et al. And he states that intact bone has a normal strain. يعني العظم مثل الازاز إذا بتمسكه بينكسر. It does not bend, it bends very minimally. We estimate that the amount of bending a bone is 2%, while on the other hand, in endochondral bone or wherever you have granulation tissue, the strain tolerance is 100%. تتعش 100% وما بتنكسر. بس العظم is much more rigid and it breaks just like glass. Strain is the deformation of material when a given force is applied to it. Hard callus will not bridge the fracture gap if there is interfragmentary motion and if it's too great. So don't forget this, please. What about the agents with inhibiting effects on bone healing? Usually interferes with bone healing. Let us speak briefly about tobacco. يا جماعة, this slide will not tell you that nicotine does not promote or does promote fracture healing. But this was one study where they mentioned that pure nicotine has been shown to increase fracture callus strength and bending stiffness in the femur fractures in rats. But this process is not well understood. But this does occur in the rat femur when nicotine is increased. But what we know about nicotine? Multiple studies implicate tobacco use with delayed healing in tibia fractures and in patients undergoing corrective osteotomies in the feet and spine. Nicotine has been shown to inhibit tissue differentiation and angiogenesis in early fracture healing and can inhibit osteoblast function. Cigarettes, the main source of tobacco in the above studies, contain hundreds of chemicals which could have independent and combined effects on fracture healing. A recent hypothesis suggested that human necrosis factor alpha inhibition causes the deleterious effects on fracture healing seen in smokers. So don't forget that tumor necrosis factor alpha inhibition can be the source of delayed healing in individuals who are smokers. Non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs are widely used agents to treat inflammation, pain, and swelling associated with acute injuries to the musculoskeletal system. Non-steroidal anti-inflammatory drugs work by inhibiting COX-1 and COX-2. Non-selective, non-steroidal anti-inflammatory drugs inhibit both COX-2 and COX-1. COX-2 through the action of prostaglandin E2, and this upregulates core binding factor alpha 1, which is essential for osteoblast formation. This is a question that one could ask in an exam. In what way do non-steroidal inflammatory medications interfere with COX-2? And you have to know that it upregulates the core binding factor alpha 1, which is essential for osteoblast formation. The effects of non-steroidal anti-inflammatory drugs are controversial, and when it comes to fracture healing. In a recent meta-analysis grouping together spinal fusion trials using non-steroidal anti-inflammatory drugs failed to find any support for the hypothesis that non-steroidal anti-inflammatory drugs use leads to increased rates of non-union. So there is a contradiction as far as non-steroidal anti-inflammatory drugs are concerned. What about corticosteroids? Corticosteroids are used in chronic inflammatory conditions, acute cases of swelling or pain, and chronically in patients with obstructive lung disease. These agents, when present during bone healing, inhibit differentiation of mesenchymal cells into osteoblasts and chondrocytes. They also have been shown to direct osteoblasts and osteocytes towards apoptosis, يعني بيموتون. The exact effect of corticosteroids on in vivo fracture healing in humans is still controversial. Clinicians are advised to weigh the potential risks and benefits prior to selecting to use these agents in the face of an acute fracture. But at times we are forced to. Patients who have chronic lung disease, who are on steroids, and they sustain a fracture, we cannot keep them off, but it's still controversial. But we know that it promotes apoptosis of the osteoblasts and osteocytes. Nutritional status. Deficiencies in nutrients essential for bone healing can be the result of insufficient intake, metabolic deficiencies, or endocrine abnormalities. The main nutrients found to be deficient are vitamin D and calcium. This is important. Vitamin D deficiency is seen across the northern hemisphere during winter months and also in cultures where the skin exposure is prohibited. In patients in which they have undergone gastric bypass, you know that calcium is absorbed actively in the duodenum. When you have a bypass, you're forgetting about the duodenum, and as a result, they will have a deficiency. So calcium in these cases should be taken into consideration. What about age? We know that fragility fractures occur in the elderly population due to decrease in bone quantity and quality. Diabetic patients with poor glycemic control have many known comorbidities, including wound healing, peripheral vascular disease, and susceptibility to bacterial infection. But diabetes also negatively influences fracture healing. Multiple studies have demonstrated increased time to union in long bone fracture as well as ankle fracture. These trends were not present in diabetics with adequate glycemic control. So if you have a fracture in a diabetic patient, always try and revert the glucose to normal levels. And it is found that in these cases, the patient won't have such a delay in bone healing. Recombinant PTH, speaking about teriparatide, which is known as Fortu. Fortu is 134 paratormon. And this we are using, I am using it in delayed healing of bones, and I have had a very successful rate in the raising the incidence of healing. But you have to follow up on the principles of PTH teriparatide. You have to know what is good and what is bad. And this increases the chondroprogenitor and osteoprogenitor cells in the early fracture callus. I've had non-unions when I gave Fortio. This is not a propaganda for the drug, no. But I'm telling you my experience, non-unions and delayed unions where I put the patient on Fortio and the fracture healed. So it's nice to consider. So, human growth hormone increases fracture callus volume. You know, as you increase the volume, increase the toughness and cellularity, and recommended recombinant IGF-1 insulin-like growth factor for use in patients with inadequate fracture repair. Platelet-rich plasma after injury, activated platelet release growth factors, TGF-B, VEGF, TGF-B1, BMP2, which can stimulate vasculogenesis, mesenchymal cell recruitment, and factors stimulating bone formation. Bone marrow aspirate. I tell you this, during the war, the civil war in Lebanon, I've used the bone marrow aspirate. You know, with all these gunshot wounds, the incidence of non-union or delayed union was high. I wanted a simple procedure. Through the innominate bone, I used to drill a small hole and put a large diameter needle. I would choose a needle quite large, 16 or 18, and aspirate the bone marrow and inject it at the fracture site. And believe me, I had a high incidence of union. Try it, fellows. What are the complications of fracture healing? We know about delayed union. Delayed union is a failure of the fracture to unite in an expected amount of time for a specific anatomic location. Many studies cite 6 months as the differentiation point between delayed union and non-union. And this number is determined on a case-by-case basis. A survey of surgeons in 2004 of Orthopedic Trauma Association defined a delayed union as an average of 3.5 plus or minus 1.4 months. You should follow up your patients on x-rays, and you can judge really which bones are undergoing a delay and which bones are being united and which bones are going into non-union. So you have to know this. The repeat survey in 2012 showed that most surgeons, 70%, describe delayed unions as occurring during the first 12 weeks after fracture. And this is very true. If you're observing the fracture, you can tell whether this fracture is going to be delayed or not. Depends on the position, on the surgeon, on the fracture, on the number of fractures, on the degree of trauma. Each patient is individualized. 88% of surgeons agree that determining fracture healing require both radiographic and clinical information. 37% of survey respondents believe long bone non-union could be adequately assessed with a combination of radiographs and computed tomography scans. Non-union. Non-union is defined as a failure to demonstrate expected radiographic and or clinical signs of healing after the expected interval. They are classified based on appearance of the fracture callus and vascularity. Fracture healing was defined by Stojanovic et al. As the ability of the patient to bear full weight on the affected limb. Example for a lower extremity, non-union. The absence of pain or tenderness at the fracture site when manual bending or compression, and re-establishing of cortical continuity on 3 or 4 cortices at the fracture site on radiographs and on CT scans. Ya Jama'a, this is common sense. You're treating a patient conservatively by means of a cast. This is endochondral bone formation. You have the callus being formed, and you want to know whether this callus has transformed into hard callus, and you want to judge. So you have to know clinically whether this is united. You use radiography. You use a CT scan at times, and these together, plus the clinical findings, the patient, if he's able to stand, if you try to bend the leg and you see that there's no pain and it's solidly fixed, this would tell you that this fracture is united. What about atrophic non-union? Atrophic non-unions are those where a fracture has failed to heal and demonstrates net bone resorption radiographically. No fracture callus is visualized, and the original fracture line is still present with loss of surrounding cortical bone. Multiple factors can contribute to the likelihood of developing an atrophic non-union. Open fractures, infection, poor nutrition, tobacco use, corticosteroid use, non-steroidal anti-inflammatory drugs use have all been implicated in various studies as increasing the likelihood of non-union. If you look at this X-ray, you see that the ulna is not united. You don't see callus. You see that there's atrophy of the fracture ends, and you see that there is a gap present. This tells you that there is no vascularity, there's no callus formation, and this needs help to be united. This is an atrophic non-union. What about oligotrophic non-union? Oligotrophic non-union is defined as the failure of bony union with little callus formation. We do have callus, and there's an adequate blood supply. In atrophic non-union, we don't have callus, and we have a poor blood supply. Some causes hypothesized to cause oligotrophic non-union are malreduction. Pay attention, malreduction, and with displacement or distraction of fracture fragments, and also poor nutritional status. And this tells you malreduction. This is an oligotrophic non-union. You don't see resorption of the bone ends so much. You see some callus to some degree, but this is due to poor reduction. If you look at the intramedullary rod on the right side, you see that there is a gap due to distraction, but you see that there is callus formation. This you don't see in atrophic non-union. It is still vascularized, okay? So keep this. This is oligotrophic. Hypertrophic non-union develops from motion at the fracture site, whether inadequate fixation or failure of fixation. Macromotion at the healing fracture site causes hypertrophy, developing callus. This is, you see that there is sufficient callus. This anterior posterior radiograph of the humerus demonstrates excessive fracture callus with a still visible fracture line 7 months after the injury. This is a classic location of hypertrophic non-union. Blood supply is adequate. They lack mechanical stability, and this prevents the completion of fracture healing. The fracture line is still present and is surrounded by a disorganized, partially ossified cartilaginous matrix. Hypertrophic non-unions go on to union after adequate fixation and stabilization of the fracture. Any surgical procedure may alter the biological environment, and every fracture fixation alters the mechanical environment. This statement, I call it a prophecy, a prophecy. When I see people who are operating on fractured tibias, on fractures forearm, and they go and elevate all the periosteum and they separate the fracture from all sides, etc. And then they apply the plate. Yeah, Jamia, you're cutting the blood supply from the fracture. You're disturbing the natural process of healing. You have to be gentle. You have to do minimal dissections to reduce your fracture. This is why we have created minimal invasive surgery. This is why we're doing a lot of our fractures percutaneously, like in fractures of the femur. We don't like to disturb the soft tissues. These changes may have a profound effect on fracture healing and are determined by the surgeon and not the patient. So you should be a good surgeon, fellows, from the beginning. All trauma surgeons should have a basic knowledge of the biology and biomechanics of fracture healing so they can make wise decisions in fracture management. During the early phase of development of principles of fracture healing, the primary goal of surgical treatment was to provide the fracture with motionless environment. High priority was given to precise fracture reduction and fixation with absolute stability, with overemphasis on mechanical stability at the expense of biology. You have to respect the biology, fellows. Fracture treatment has evolved with recognition of both mechanics and biology. You should not separate the two. Precise reduction and absolute stable fixation is not required in every case and may come at a biological price. Indirect reduction takes advantage of the soft tissues and the blood supply to the bone fragments, which will come into alignment when traction is applied to the main fragments. This reduces surgical trauma and helps to keep the bone alive. I repeated this so much so that you will respect it. Bone has evolved to heal with some movement between the fragments, mazboot, and without each fragment being in contact. Relative stability allows the surgeon to control the movement to allow healing while maintaining fracture reduction. That will allow early rehabilitation and good functional outcome for the patient. A more flexible fixation should encourage the formation of callus, and indirect reduction will reduce operative trauma. The main goal of fracture fixation is to achieve prompt and, if possible, full function of the injured limb. Although the reliable fracture healing is only one element in functional recovery, it is essential for a good outcome. Fracture fixation is always a compromise that balances biology and biomechanics. It is often necessary to sacrifice some strength and stiffness of fixation, and the optimal implant is not necessarily the strongest or the stiffest available. Under extreme conditions, the mechanical requirements may gain precedence over biological demands and vice versa. Similarly, the choice of implant material is a trade-off. Example, the mechanical strength and ductility of steel versus the electrochemical and biological inertness of titanium. We know that titanium is elastic, so you have to realize comparing it to steel, it's more rigid. We prefer more of a somewhat elastic so as to promote callus formation. Clinical decisions must always take into account the patient's age, the expectations, the comorbidities, and psychosocial factors. Psychosocial factors play an important role. I'll tell you why. Inherent biological deficits may need to be overcome, or expectations must be lowered when a favorable outcome is less likely. No decision can be made solely on the basis of radiological evaluation. This is the first half of this lecture. Dr. Khalid, let me take a 5-minute break so as to relax my voice.
Okay, sir. You can.
How is it so far? Was I clear?
Yeah, everything is clear. Thank you.
Are the boys satisfied?
Yeah, sure. Now take rest. Okay, 5 minutes, drink something.
Okay, 5 minutes.
Yeah.
And if there's any questions, I could answer them at the beginning of the next component of this lecture.
Okay. Thank you. يا صلاح يا شباب، السلام عليكم. إذا في سؤال خلوه بورقة، يعني الأسئلة اللي تشتوها. يعني مثلا أنا أقترح حد يسأل الجروث هرمون لما كيف نعطيه للبيشنت with bone fracture، وإيش السايد إفكتس مثلا، وإيش أي حاجة تشتوها.
Khalid, any questions?
Now the colleagues they can answer. يا صلاح حد عنده سؤال؟ صلاح.
يا دكتور في سؤال
ايش السؤال كله؟
What's the role of the bisphosphonate in fracture healing?
Khalid, what's the what?
عيد يا صلاح ايش؟
What's the role of the bisphosphonate in fracture healing?
And the biphosphonate.
Biphosphonate.
You see, let me tell you, I didn't mention biphosphonates for one reason. Biphosphonates interfere with remodeling, and I don't like its use in the healing of fractures immediately. When it comes to remodeling, bone is interfered with. You know, the biphosphonates interfere with bone remodeling. So I wouldn't encourage it at the beginning. Later on, yes, but not during the first 6 weeks of fracture healing. What's your opinion? Tell me. Khalid. يا خالد.
دكتور جون معك. دكتور جون كان عندي سؤال.
أنا بيهمني to carry out the discussion. لأن his question is very good. He noted that I did not include biphosphonates. لأن أنا personally I don't believe in it, and this is what the literature says, that what does biphosphonates do? It stabilizes the hydroxyapatite crystal. So bone won't be able to remodel in this case. Why do we give biphosphonates to women? You know that the quantity of bone is much less. And being that the quantity of bone is much less, biphosphonates protect the hydroxyapatite so that it won't be destroyed, so that it won't become less.
Yeah.
This is the principle. It does not increase bone formation. It protects bone from being destroyed, especially in women during menopause. You got the point? It surrounds the hydroxyapatite and protects it from being destroyed, from being eaten up, so that the woman won't have more osteoporosis.
Thank you, sir. Sir, I want to ask one question. The simulators for bone healing, it is very nice.
I will be discussing it. Electromagnetic stimulators. These I will be discussing in the second part, I hope, if I have time.
Okay.
Then I can start if you want.
Okay, start. خلاص. Yeah. Thank you.
What are the characteristics of bone? Now we're coming into biomechanics. نشوف ليه ما بتغير ليه In fractures of bone, a fracture is always the result of single or repetitive overload. The fracture occurs within a fraction of milliseconds. It results in predictable damage to soft tissues due to rupture and implosion. Implosion means explosion-like process. You have a rapid separation of fracture surfaces and creates a void and results in severe soft tissue damage. Bone is a scaffold. كلنا بنعرف bone is a scaffold. It supports the soft tissues. It protects the soft tissue structures. And besides, it enables locomotion and mechanical functioning of the limbs. يعني لو ما عندنا عظم ما فينا نمشي. نصفي مثل one of these animals that use their body just to move. In considering a fracture and fracture healing, the brittleness of bone is of special interest. Bone is a strong material, you should know it. However, it breaks under small deformation. This means that bone behaves more like glass and not like rubber. إذا بتلاحظوا بأول اللكشة قلت لكم when you have a strain on granulation tissue, it bends 100%. On bone, it's only 2%. Why? Because it's hard. And it behaves مثل الإزاز. It breaks. And when it breaks, it shatters. At the onset of natural fracture healing, bone cannot bridge a fracture gap that is repeatedly subject to excessive displacement. For an unstable or flexible fixed fracture, which is relatively stable, a sequence of biologic events was what we spoke about repeatedly takes place. Resorption of the fracture ends initially increases the fracture gap, and this reduces the strain at the fracture site. Strain means the force of bending, So when you have resorption, we know that every fracture there is some resorption of the ends of bone and the gap somewhat increases. So this allows biomechanically the strain to increase at the fracture site. The lower strain environment promotes formation of bridging callus, which then increases the mechanical stability of the fracture. Once the fracture is solidly bridged, full bone function is restored. Internal remodeling then restores the original bone structure, a process that can take years. To appreciate why bone fractures exist in certain patterns, one must understand that bone is weakest in tension and strongest in compression. Therefore, when a fracture creates tensile stresses in a particular region of a loaded bone, failure will generally occur first in that region. Let me tell you, إذا بتمسكوا عظمة وبتقطع جوا, where does it break first? It will break on the convex side. And this is the strain side. مطرح ما موجودة material elongation causes tension to tract. The compression side is on the concave side, and the soft tissues are not so damaged on the concave side, but they are damaged on the tension side, and there is stretching and tearing and sharing of the soft tissues. Pay attention. بدي اياكم تطلعوا على هالصورة. طلعوا كيف bone we're bending it. As we bend it, it doesn't break on the concave side. It breaks on the convex side, the tension side. In this manner, the crack progresses through the bone transversely until a complete fracture occurs. The concave surface is subjected to compression اللي حكيته repeatedly, so the crack does not initiate there. The rectangle distorts at the bone twists with one diagonal and rectangular elongating and the other shortening depending on the direction of the twist. This causes a spiral fracture. Yani, when there is a twisting motion, the rectangle changes and it becomes oblique-wise, and it gives us a spiral fracture. This shows you when you're bending bone, you're stretching it, it no longer is parallel to one another. It becomes diagonal and it gets longer. And as it twists, it becomes spiral. There is torsion, which shows you at the end of A. If there's torsion, you end up with a spiral fracture. The region of the bone with the smallest diameter is usually the least stiff region. إذا بتطلعوا على التibia قبل الأنكل, it is the narrowest, and this is the least stiff region, resulting in the greatest torsion of the surface and generally the location of the fracture. This explains why torsional fractures of the tibia often occur in the narrow distal third. إذا بتلاقوا the ski boot, you have a twisting motion. It's the narrowest area. Therefore, you have a spiral fracture. At very high loads, such as during impact, fractures, crushing, or comminution of bone also occurs, especially at the weakest metaphyseal ends of a long bone. وهلا بدي الفت لكم نظركم بالtibial plafond fractures. Many times the force is more proximal, but as you go distally, you have trabecular bone and you have narrower bone, and therefore the trabecular bone is weak, it is metaphyseal, and as a result, you will end up with fractures. The trabecular bone at the metaphyseal ends is weaker in compression than the diaphyseal cortical bone, and these easily share. Because of this, it is unlikely that sharing failure will occur in the diaphysis caused by pure compression. A butterfly fracture results from combined bending and compression. It starts by bending, there is a gap. Then, through the mid aspect of the bending, there's a compression force and it causes a butterfly fragment to come out. I'll speak about this later. Bending load causes the fracture to start to fail in tension, producing a transverse crack. But as the crack progresses and the remaining intact bone weakens, it starts to fail in compression, causing an oblique shear fracture line. As the ends of the failing bone are driven together, a third fragment, the butterfly, may result, as the oblique fragment splits off. خليني نفرجيكم إياها. Now, we spoke about the spiral and oblique fractures, and then we spoke about fractures occurring in the distal end, secondary to a stronger cortical bone. And I want to come to the other one. I will come to it. Bone mass normally peaks at around 25 to 30 years, after which you have a decrease up to 1% annually thereafter. Drivers who were braking during a crash were shown to be much more likely to injure the right foot compared to their left foot. Why? لأن عم بيستعملوا right foot أكتر, and when they're braking on the brakes, the force is coming on the right foot. If the Achilles tendon applies a load to resist this forced dorsiflexion on the right foot, on the brake pedal, the combination of these two loads, meaning traction of the Achilles tendon and the force of the pedal applying a dorsal force, lead to a 3-point bending load of the calcaneus with the posterior facet of the talus as the fulcrum. Let's come to this. Some fractures that combine bending and compression demonstrate transverse cracking as a result of bending, followed by an oblique crack, characteristic of a compressive failure. So they occur hand in hand. At first, you have tension, then you have compression. The butterfly fracture with additional splitting of the fragment secondary to the initial fracture is an example. Let us come over here. This is what I was searching. Now, if you have a bending force, let's say this is the femur. I hope my pointer points to it. This is intact, but the force is being applied here, and the force being applied here, and the fulcrum is over here. So what happens? You start with the transverse fracture, bending, and it could end up as a bending fracture, which is transverse. On the other hand, you can have a butterfly fragment where the tension force is converted to a compression force, resulting in a butterfly fragment. On the other hand, if you have a twisting motion, you'll end up having a spiral or a more or less oblique fracture. When a gap is left on the cortex opposite that to which a plate is being applied, this is something very important for the young orthopedics. If you apply a plate with some distraction, what happens? When a gap is left on the cortex, opposite that to which the plate is attached, bending of the plate at the fracture site can cause the plate to fail rapidly in bending. Compressing the fracture surfaces not only allows the bone cortices to resist bending loads, but the frictional contact and interdigitation help resist torsion. Let me show you. This is a plate being applied. You have a gap here. Don't forget that there's always a compression force element, and this compression would try to close this fracture site. What happens? The only way it can close is by bending the plate. And in addition, the plate might not only bend, it will break. When you apply a plate with compression, both torque and compression will stabilize the fracture, and it won't have to bend to lead to closure of the gap, and there won't be any load on the plate. A fracture produces a loss of bone continuity that results in pathological deformation, loss of support, function of bone, and pain. Surgical stabilization may restore function immediately and alleviate pain. The patient regains pain-free motion or mobility, allowing early rehabilitation and reducing the risk of conditions like complex regional pain syndrome. So this would tell you why we like to operate these patients. We like to provide them with relative stability. You can apply absolute stability under certain conditions. The advantage is that it promotes early motion of the joints, and there is enough reason to say that this will help in preventing complex regional pain syndrome. So let's not forget this. Fracture of bone ruptures the blood supply, the vessels within bone periosteum, spontaneously releases biochemical factors and help induce bone healing. In fresh fractures, these agents are effective and scarcely need any boost. The role of surgery should be to guide and support this healing process. Although a fracture process, it triggers biological reactions such as bone callus and bone resorption. These two processes depend on the intact blood supply that we spoke about. So I want you to realize that all these factors take place. You have to know how to transport a patient. If you're transporting a patient without a splint, when he fractures, then you have further injury and further causes to delay in healing and non-union. So you should always splint the patient, and I'm sure you know that this is basic. Patient resuscitation, hypovolemia, hypoxia, and coagulopathy will increase damage to the injured bone and soft tissues and must be corrected early in patient management. Comorbidities such as peripheral vascular disease and diabetes should be taken care of. Dead bone can only be revitalized by removal and replacing the creeping substitution through osteonal or lamellar remodeling. And this gives you the answer why biphosphonates I don't like. Because if you prevent remodeling, then you cannot remove this bone, dead bone, a process that takes a long time to complete. Necrotic tissue, especially bone, predisposes to infection and sustains it. You have to take this into consideration. Another effect of necrosis is the induction of internal aversion remodeling. This allows replacement of dead osteocytes by results in temporary weakening of the bone due to transient porosis, which is an integral part of the remodeling process. Always I repeat this. This is often seen immediately beneath plates. And for this reason, the AO people have created minimal contact plates to prevent this from occurring, and can be lessened by reducing the contact area of the plate, which fosters the periosteal blood supply and reduces the volume of a vascular bone. An immediate reduction of bone blood flow has been observed after fracture or osteotomy, with the cortical circulation in the injured parts of bone healing reduced by nearly 50%. This reduction has been attributed to physiological vasoconstriction in both the periosteal and medullary vessels as a response to trauma. I don't want to go into this, but I would like to speak about biology and biomechanics in bone healing. Microangiographic studies have demonstrated that much of the vascular supply to the callus area is derived from the surrounding soft tissues, which I have repeatedly mentioned. And this is a good reason not to strip any soft tissues. This shows you of how the blood supply surrounding the fracture site is very important. You should not strip the periosteum because through these, the return circulation occurs. Perfusion of callus is the most important and may determine the outcome of healing. Bone can only form when supported by vascular network, and cartilage will not persist in the absence of sufficient perfusion. You need a good circulation for cartilage to die out and be replaced by bone. The angiogenic response depends upon both the method of treatment and induced mechanical conditions. The vascular response appears to be greater after more flexible fixation. I've mentioned this, perhaps due to a larger volume of callus. High strain in tissue caused by excessive instability reduces the blood supply, especially in fracture gaps. The operative procedures during internal fixation of fractures alters the hematoma. That's why we love to keep the hematoma at the fracture site. We love not to expose the hematoma. We love to do indirect reductions of fractures. We don't care about perfect reductions. We care about permanent, good alignment. Following intramedullary reaming, maslan, when we insert an intramedullary nail, if we put too tight a nail, in the past we used to ream and put a press fit. Well, this disturbed the endosteal circulation. This was bad. We don't like, we like to leave a space to allow for blood to return to the fracture site. So reaming too much is too bad, very bad. Reaming too fast also damages the blood supply. When you're reaming, you're increasing the pressure within the medullary canal by 400 to 600 times. And this is bad. So damage to the blood supply is minimized by avoiding direct fragment manipulation, minimally invasive surgery, and use of external or internal fixators. What do we mean by internal fixators? Are low contact plates. These are fixators in a different way than the external fixator. And this does not destroy the periosteal blood supply. So in conclusion, fracture healing can be divided into two types: primary or direct healing by internal remodeling, secondary or direct healing by callus formation. Direct primary bone healing occurs only with absolute stability and is a biological process of osteoidal bone remodeling. Note that the primary bone healing was not the goal when the technique was first described by Dennis. The aim was anatomical reduction and stable fixation to allow early rehabilitation. Primary bone healing was observed as a byproduct of this method of fracture fixation. Indirect healing, we spoke about it so much, I will not go between it. There is a difference in healing between cortical and cancellous bone. As opposed to indirect healing, in cortical bone, healing in cancellous bone occurs without the formation of significant external callus, after the inflammatory stage bone formation is dominated by intramembranous ossification. This is due to the tremendous angiogenic potential of trabecular bone, as well as the fixation used for metaphyseal fractures, which is often more stable. In unusual cases, with substantial interfragmentary motion, intermediary soft tissue may form in the gap, but this is usually fibrous tissue that is soon replaced by bone. Now we come to the the second and final part of the lecture. I know that many of you could be bored, but I was bored while I was preparing this lecture, but it gives us basic information. A stable fracture is defined as a fracture that does not visibly displace under physiologic load. Fracture fixation with absolute stability means that there is no motion at the fracture site under physiological load. The degree of stability determines the type of fracture healing, as we mentioned. Fracture of a bone often produces an unstable situation. Obvious exceptions are impaction fractures of the metaphysis, undisplaced fractures with intact periosteum, abduction fractures of the proximal and of the femoral neck, and green stick fractures. These fractures do not require reduction, and stabilization is only required if the fracture will deform under the physiologic load. The fractures is considered unstable. The aim of fracture stabilization is to maintain the achieved reduction, restore stiffness at the fracture site, thus allowing function, minimize pain related to movement at the fracture site. This is a patient from Vietnam. He was shot in the field, and this left as such. You see that this patient here side to side by excessive callus formation, of course, in a slightly deformed position. Fixation with absolute stability aims to provide a mechanically neutral environment for fracture healing. No motion at the fracture site. However, this also reduces the mechanical stimulus for repair by callus formation, and so healing occurs by remodeling, primary bone healing, the AO people, rigid compression at the fracture site. Fixation with relative stability aims to maintain the reduction and still keep the mechanical stimulation for fracture repair by callus formation. Okay, so I'm not going to go into detail, but you have to realize that there are multiple methods of healing a bone, and each should be chosen during the proper case. Yani you should apply many indications and contraindications to your treatment. Now, in the past, we used to like to do everything closed. We used to apply casts. We used to apply traction. Traction kept the patient in bed for months. Nowadays, with the presence of advances in anesthesia, improvements in sterile technique, advances in technology of internal fixation has changed the principles. There is a minimal risk of infection, and we internally fix on a reliable basis fractures that were previously not fixable. Operative treatment now dominates the treatment of musculoskeletal trauma to such an extent that residents today have far less training in the principles of closed management. Patients expect not only that fractures will heal, but also that they will heal in an anatomic position with restoration of normal function. This is what the patient wants. If you reduce a fracture and it's acceptably reduced by close means, the patient looks at the x-rays and he says, "This is not a proper reduction," and he would complain about it. Often these expectations are unrealistic in view of the severe injuries that occur in our high-velocity society. Many injuries are now occurring in the context of multiply injured patients, what we spoke about last week, where the need for early mobilization makes non-operative techniques impractical. Let's say if you have a patient who has fractures of both humeri, you have to do something to let him self-supply himself. Surgical techniques offer the ability to restore anatomy close to normal. Rigid fixation obtained often allows early mobilization and rehabilitation and leads to a better outcome. Modern orthopedic surgeons must be as skilled in non-operative as they are in operative techniques. I know many of you young people are listening to this talk and say, "Why should I know about closed reduction?" Well, in many ways, we use closed reduction still, but of course, it's much less than before. Especially in children, we do use quite a bit of closed reduction. And it's very important that you know about it. A sound knowledge of non-operative techniques also makes the use of operative techniques more effective and safer. Closed treatment requires as much thoughtfulness, technical expertise, and attention to detail as does surgery. And I will be showing you this. The initial healing process of a fracture in incising callus is formed that begins to immobilize the fracture fragments. Early during fracture healing, motion can still occur at the fracture, but translation of the fracture fragments and shortening are usually impossible after initial incising the callus has formed. Yeah, in the past, we used to put the patient in traction and callus would form. We always used to be afraid of shortening of that extremity, but there is definite proof when the fracture is surrounded by a callus, and in particular a thick callus, no shortening can occur, but bending can occur. So keep this in mind, fellows. John Lee said, if you grip the fracture site with your hand would be like a callus. And when this hand is tight, there's no way that the fracture would shorten. Most bone in fracture callus comes with endosteal tissues, which quickly fills in the incising callus. As this becomes progressively thicker, total immobilization of the fracture bone ends occurs. This method of healing has the mechanical advantage of producing a callus that is much larger in diameter than the fractured bone. Let's show. This is what Charlie said. If you have a fracture and you grip this and you grip it, your hand is the callus. And if this callus is of sufficient amount, there's no way that the fracture will shorten, but it will bend. It will bend, but not shorten. After complete consolidation, in fact, this thickened area of bone is often stronger than the unaffected shaft. And that's true. Many times in children, when you have a fractured forearm and you have callus formation, these children can come back with a fracture just adjacent to the callus, not within the previous fracture. Why? Because it is weaker than the bone formed by the callus and in the region of the callus. The bone ends themselves are usually somewhat avascular because of the injury and do not directly participate in the early phase of healing. This is very true. Now, this shows you of how when callus is formed, if you straighten it, it will return to the original length when the callus formed. Now, there are certain surgeons who say in fractures of the femur, when you have a child coming with a fractured femur, and you see that there's shortening of the extremity, if you apply traction on that extremity, you might regain length. But once you remove the traction before callus is formed sufficiently, it will only shorten to the level at the time when the patient came with the fracture. Why? Because the soft tissue around it swells, and you have a hydraulic function which prevents shortening, and on the other hand, it can prevent lengthening. Now, once completely immobilized within the cancellous, bone ends are slowly revascularized and remodeled. The large peripheral callus is slowly resolved and the shape of the bone returns towards the normal shape. And this type of union is virtually 100% successful. You have to keep this. And this occurs particularly in the ribs, the clavicles, membranous bone, and in the mid-diaphysis of such bones as the tibia. The limitations of blood supply and excessive motion produce في شيء يا خالد في شيء
دكتور ما ادري من دخل خلاص استمر ما فيش حاجه
اقول لك تعبوا او بكمل
لا كمل بالعكس هم مرتاحين لا ما في شيء.
Okay, by attempted use of the limb commonly lead to non-union, so you have to be careful. You cannot compare apples and oranges. You cannot compare a flat bone with a long bone. A long bone, such as the tibia, if you have continuous motion, you go into non-union biomechanically. So you have to take this into consideration, besides having a low blood supply. Now, the purpose of non-operative treatment methods then is to hold the broken bone in a position as close to its anatomic position as possible to prevent malunion and to reduce excessive motion in order to prevent non-union and to allow early function than would otherwise be possible. Immobilization substantially reduces pain. Surgery involves soft tissue dissection, I repeatedly tell you, and direct mechanical trauma to bone. It reduces the blood supply to bone and surrounding soft tissues, except for closed intramedullary nailing, and we spoke about this. With rigid fixation, both bone union occurs by direct osteonal bone formation. Now, about closed reduction, I would like to mention that internal fixation, it has some indications in children, but not as often in adults. We do have to do an open reduction in displaced intra-articular fractures, fractures through the gross plate, avulsion fractures with wide displacement, as in the medial epicondyle of the elbow, some juxta-articular fractures, and femoral fractures in older children, particularly those with severe, life-threatening multiple injuries. Supracondylar fractures of the humerus are now routinely treated with percutaneous pin fixation. Children's fractures of the lower extremity are commonly accompanied by some overgrowth. Don't forget this. If you put in end-to-end, you see that you can have a significant overgrowth. And you should warn the family if they want it to be done, this could occur. For this reason, in children, at times, we accept side-to-side reductions to avoid this overgrowth. Non-union is rarely a problem in children, despite prolonged immobilization. In contrast to adults, the vast majority of children very quickly regain normal joint motion and muscle strength. Children's fractures are often treated with closed techniques. Undisplaced fractures are nearly always treated without surgery. Internal fixation is rarely indicated as the fracture is in anatomic position and will heal rapidly. Notable exceptions include undisplaced fractures of the femoral neck, which usually require percutaneous pin or screw fixation to prevent displacement. But if you have a fractured head of the radius, it's non-displaced, but in anatomic position. I will not operate this patient. If I have a fracture of the olecranon and it's non-displaced, I will apply a splint. I will treat it closed. Not every fracture which exists you should treat open. Poor bone quality, osteoporosis is a common problem. Non-operative treatment methods can severely impede the mobility of the elderly. Methods such as cast bracing may be indicated to avoid prolonged bed rest. Compromises are usually necessary so that early rehabilitation is possible. Unfixable fractures. There are certain fractures. No matter what you do, you can have a poor result as a result of severe comminution, particularly with bone loss. And this is a common problem following high energy trauma on our new autostrats. Many intra-articular fractures, such as those of the tibial plateau. How many of you have seen a tibial plateau fracture, which is so severely comminuted? It's true we have certain approaches that we use in the 3-column theory and in Schatz's classification. We use plates and everything. Many times in the severely comminuted fractures, meaning types 4, 5, and 6, you can get so much comminution that no matter what you do, there's still some irregularity of the joint. And many times in the elderly, we end up doing a total knee replacement. These cases require external fixation, nothing else. Systemic contraindications to surgery, severe medical illness may contraindicate surgical intervention, and certain systemic diseases, such as immunodeficiency, may make the hazards of surgery sufficiently high that non-operative methods are often required. Local contraindications to surgery are severe skin lesions, infections, local skin infections, etc. Psychosocial problems. This is one of our biggest problems. When you have a crazy patient who has a fracture, who does not cooperate, and no matter what you do, he ends up refracturing the case. So you have to be careful when you choose to treat such patients. So what about the closed reduction? I want to mention briefly about closed reduction. When you have a fracture like this, meaning that the tension side went and the compression side, the soft tissue is still intact, but on the tension side, the soft tissue has torn. When you bring it back into place, the soft tissue on the compression side acts as a splint. and it helps in the reduction and maintenance of the reduction. So I want you young fellows, this is one of our principles of closed reduction. I'll show you this because I don't want to come into it in detail. This is a patient who has a fracture of both bones, and both bones are off. Now, if you want to make use of the soft tissue on the compression side, you'll find it shortened. If you apply traction from now to tomorrow, you won't be able to get it back in place. And the way you should do, you should increase the angulation until you get an end-to-end fit of the fracture fragments, and then you straighten the forearm. Ya Hakim, apply traction on it. If you say from now to tomorrow, you won't be able to get it in place. You have to increase the deformity, bring the bones end to end, and then get your reduction. So this is thing as cases like this. Traction, we don't like to apply traction. Why? Because of the swelling of soft tissues. The soft tissues, it acts like a hydraulic. You cannot stretch the soft tissues to get the reduction. You have to increase the deformity because you have a lot of edema, you have a lot of bleeding, and this together increases the tension or the forces on the fracture, preventing it from reducing while under traction. I want to show you, this is a patient comminuted. You have to increase the deformity, then get the fracture. So don't forget this. Transverse fractures, where they are still in place, you don't have this problem. Okay, let's look at the colles fracture. This is a colles fracture. You have to use the 3-point. You know, on the dorsal aspect, the colles fracture has shortened, and this gives you the silver fork deformity. The depression is the elevation and the compression of the fragments is on the dorsal surface. The volar surface is not fractured, comminuted. Yeah, it's still a simple fracture. So we use a 3-point fixation, meaning that, let me see if the pointer is here. You see that there's compression at the angle of the fracture. You have forces being applied here and forces applied here, while this force is being applied in the opposite direction. This is a 3-point reduction in fractures of children of both bones of the forearm. You have to increase the deformity if it's completely displaced. Put an end to end. Yeah, gentlemen, this would help you even in percutaneous fixation of fractures. Increase the deformity, put the fracture ends point to point on the end, and then straighten the extremity. It will help you even in open reductions. How many times have you had cases where you apply traction and apply traction and apply traction, and it's not reduced? The rest, in the second year, the third year, resident comes and wants to help. This is wrong. You have to increase the deformity, put the edge on the edge, and then get your reduction. I spoke about delayed union. You have to think of preservation of function. You have to have all the materials in the operating room when you're operating. Your case should be pre-planned. You have to know if this is not successful, then this method will be successful. There is no excuse for saying that I didn't have this instrument or I didn't have this size. It is embarrassing when you have a bad result secondary to your surgery and you have to present it in a conference. What would your excuse be? We didn't have the proper size. This was your fault. You didn't do the essential, proper preoperative planning. Keep this in mind. Don't forget that you can use stockinette. Well, in acute fractures, I usually don't use stockinette. It interferes with the reduction if I want to do a closed reduction. My second cast change, I routinely use stocking. So you have to keep this in mind. You can use, in the acute cases, stockinette just to trim the edges of the cast, like this. You can put it like this and apply your stockinette. When you apply stockinette, make sure you've made this cut so as not to have wrinkles underneath the cast, because you can have pressure areas and sores. So you have to pay attention to this. These use web roll. This is web roll. They have it in multiple sizes, and you have to pay attention. You have to always pay attention from compartment syndrome. First of all, if you apply too much traction and maintain the traction on a fracture with swelling, this increases the pressure within the compartment, and it will increase the chances for compartment syndrome. Now, we have two types of casts. We have the cast of plaster of Paris, and we have the fiberglass. And we have, even in the plaster of Paris, rapid healing, rapid solidifying, and solidifying of the cast, or having an anhydrate at 5 to 8 minutes or at 2 to 4 minutes. Well, I'll tell you, in club feet, you have to use plaster of Paris. It has to be quick. You have to reduce the deformity and apply the cast. We use the short time cast. While in adults, where we have to mold and maintain, we need time, we use the 5 to 8 minutes plaster of Paris. Plaster of Paris has an advantage over fiber cast, because nowadays we have fiber cast being used quite often. We cannot mold the fiber cast. What you can do is apply a cast, and to maintain the cast, you can apply, once it's dry, apply a roll of fiber cast on it. There are certain cases, of course, where you have a fracture that is nearly healing, you can apply a fiber cast. The advantage of fiber cast, you all know that water does not damage it, and it's much lighter than the gypsum. These are the barriers. You have slabs, so you have to be careful and know about this. You have to have a marker to mark the timing each time you apply it. You have to have a cast room with all the workup, all the cast cutting equipment. You have to have duckbills, spreaders, all available to change the cast. And I wanted to speak briefly about Sarmiento. This is part of closed reduction. What he does, he applies casts on the weight-bearing areas for 3 weeks, 1 month, until there is sufficient amount of casts, callus. Then he applies his splints. And what he does, he was, I think, one of the inventors of patella tendon casts, of how we apply it. And then he applies this, mind you, 3 to 4 weeks later, so as to maintain the deformity, so as to correct the deformity. I told you, once callus is formed, then there's no shortening, but there is bending. And this is the whole purpose of the Sarmiento splints. Okay, so please keep this in mind. Another point I'll tell you, residents, at times you have nobody to help you in applying a cast. Put a tape around the toe. Ask the patient to help you. He will hold his leg in extension by means of the tape while you apply the cast. Okay? So enough is enough. I think I bored you enough. And what is left is a repetition of what I mentioned. Okay? I don't want to put you to sleep. We're nearly 2.5 hours. and I'll tell you have a good day. Okay, sir? Thank you.
Okay, thank you, sir.
Khalid,
ها دكتوري، ها دكتور.
إن شاء الله I wasn't bored.
لا والله كلنا منصتين ومستمعين لك. تسلم، كل شيء تمام. محاضرة يعني ريفيو رائع جدا للكل، للجميع، لنا والشباب.
Would you like to carry on these lectures؟ هاي لو وقت بدكم توقفون قولوا لي.
اللي بدك إياه، يعني إيش ما بدك، يعني باقي
أنا
حاجة
مبسوط،
مثلاً؟
أنا عم بعطيها، بتعرفوا كلهم بيعرفوني إنه بحب أحكي كثير، بحب
الله
أعطي
يعطيك
لكشر.
العافية. لا تمام، كل شيء تمام. الدكاترة الدكتور عبد السلام اللي موجودين.
عبد السلام ما عم بيحكي.
لا هلا يحكي.
وينك يا عبد؟
دكتور عبد السلام
ما بيحكي.
هلا بحكي معك.
الآن
سامع كل شيء. سامعني. Thank you very much for very, very important lecture. The base of medicine, the base of orthopedic.
Thank you. And I think this is the basis of orthopedics. This is the basics. أنا من هيك اللي بقول لك these are important. هلا the next lecture will be in 2 weeks. ما هيك خالد؟
ايوه بعد اسبوعين بالضبط، مش الجمعه الجايه اللي بعدها.
It will be more interesting. Then we will be discussing diseases, conditions. Okay? Okay. So I'll tell you good night. Have a good day.
Thank you very much sir. والكل يسلموا عليك من صنعاء ومن عندي ومن عدن، والكل يسلموا عليك جميعا. الله يحفظك. شكرا.
Thank you.
يا صلاح.
دكتور يسمعك.
خلاص شوف الدكتور جون بيزيد يرسل أسئلة المحاضرة.
أنا بعت لك الأسئلة لهاللكشر.
اوكي، وانا بخليه حتى سنه ثانيه يعني يختبروا فيها، لانه هي بيسك لهم ايضا، لان احنا المحاضرات اللي هي متقدمه زي الريكونستراكشن والتيومرز والكذا بنسويها من ثالثه ورابعه وخامسه. هالمره بنخليها من سنه ثانيه ايضا انكلودد لهم، عشان يعني لانها بيسك وكويسه.
صدقني يا خالد لازم الكل يسمعوا.
أيوة.
ان كان من السنه الاولى او الخامسه. ليش بقول لك اياها؟ لان لما بنعيد اللكشر واحد مرة تاني بفوت بالراس. they will not forget. ما تخلوا الثانية أو الثالثة. What we do, we give the same exam to everyone. The first, the second, third. And we score them according to the level of training. يعني تحسب لنا إياها لازم يجاوبوا 60% قبيل 100% يلي بالسنة الخامسة. You got what I'm trying to say. Okay. يلا باي باي.
حاضر، شكرا لك، اوقاتك طيبة باشا. شكرا، باي باي.